So let me introduce Pradeep, then our first speaker of the module. So thanks for joining, Pradeep. You have an extensive expertise in blockchain, finance, technology, and healthcare. And you've been the CEO, COO, CIO, CTO in various innovative technology healthcare companies for the last 26 years, deeply involved in designing, building solutions for public programs such as Medicaid, eligibility and enrollments, children health insurance program, admin, Medicare claims, SNAP, TANF. I have no idea what does it mean, so maybe you will tell, administration and payment, child welfare program administration, and many others. So it's great to see as well that you have a lot of experience working with commercial insurance company as a top tech executive, where you've built 4 healthcare IT companies and been at the top of Deloitte Technology 500. And you've been working with the healthcare initiative of the Obama administration to design, build several public program solutions from 2012 to 2017. So it's quite a lot of great and fantastic experience. I'm sure we can spend 20 minutes on each of them, but we'll be able to only give you 20 minutes now to speak about putting the patient first to streamline healthcare and payments. So the floor is yours, and thanks for joining, Pradeep. Looking forward.
It's my pleasure to be here, and thank you, Yannick, for the very kind introduction. And hello, everyone. My name is Pradeep Goel. I'm the CEO of Solve.Care, and my background is in insurance. I spent most of my career working for or in the insurance sector, and my last major engagement was as the CIO of Blue Cross Blue Shield of North Dakota, owned by Northern Mutual Insurance Corporation. But my experience has been primarily in facilitating better care for my membership in working with my provider network, both in the commercial sector and in the public sector, which are some of those acronyms that Yannick talked about. SNAP and TANF are public programs run by the US government in the state level. Medicare is a national program for the elderly, and Medicaid is a state program in each of the 50 states for the indigent and the poor population, those who are underserved. So I have spent a lot of time in the population health management of large groups, be it disease-based or need-based. And the Solve.Care organization and what we are doing is really building the platform that I would have loved to have had when I was in the CIO chair at Blue Cross or when I was helping implement Medicaid expansion and or population health programs for diabetics or pregnant women and so on. So I'm very excited to share with you what the possibilities and the new technology stack enables that previously was either incredibly difficult or incredibly expensive or both. So in many ways, what I'm going to talk to you about is essentially the experience and the need that I encountered in my experience and in my career, and decided that there is no solution or platform in the world that really meets my need to serve my membership and my provider network better. So that resulted in Solve.Care being created from the ground up to serve that yawning gap in the healthcare delivery. So I'm going to share with you a brief PowerPoint here with the hope to visualize a fairly complex topic. So let me bring up the introduction. So first and foremost, I want to give you the premise. The premise of today's conversation is that there are many digital health initiatives around the world, launched regionally or nationally, and they all suffer from this issue of adoption and impact. And I have personally overseen billions of dollars invested in digital health networks for population health management, care coordination, disease management, payment automation, and so on and so forth. And they all struggle in all scenarios, be it commercial or government or institutional. We struggle with getting the patient to adopt and use the network in a persistent, consistent basis. We might get 5% adoption at the launch, 7% over time with huge amount of outreach and engagement, but we never got into the 50, 60% adoption. And when you root cause analyze that, you realize that the patients have an issue and providers have an issue, physicians have an issue with the data ownership, data custody, and use of data. So in many ways, addressing that problem is at the heart of getting any kind of digital health networks, be it population management, disease management, payment management, benefit administration, or all of the above, can actually achieve their desired outcome. Now, Solve.Care was started with a simple statement that we need to make healthcare work better. And this is not something orthogonal to the interest of the insurer either. We all know that to bend the cost curve, we have to have the physician and the patient be not orthogonally aligned to us, that there cannot be this adversarial relationship where everything the insurance company does is seen as for their own benefit. And a big reason for that adversarial stance that everybody takes, be it the physician or the patient or we ourselves as insurers, is because it becomes a single factor of how are you using my information? Do you really have my best interest at heart? So we are looking to address that fundamental disconnect between whose interest is really driving the network and its underlying premise. Having said that, this is what the picture looks like in most cases. The patient feels fairly disconnected from whatever we are doing as an insurance company, as an employer, as a group administrator, as a hospital or a medical institution, even as a government agency. There is a lot of HIEs and HIXs or information exchanges and EDI gateways between these entities, but none of them extend to the patient. So that we, by definition, end up isolating the patient. Now, we've all seen this picture where we say, well, let's put the patient at the heart of it. Guys, that's really, really difficult to achieve because putting the patient at the heart of a patient-centric model requires us to change our approach in interacting with the patient. And it starts with deciding where the data custody is and who has custody and who has ownership. And typically, data custody and data ownership are same. Whoever has custody has ownership, but that doesn't work for the patient because the patient's never going to have custody of all their data, but they need to have ownership of their data for them to trust and engage with whatever initiative you and I are launching, whether it's commercial or government program. So to achieve that is a very difficult thing, and it is not a function of whether there is a great innovative device or a great innovative medical application where patient can and should enter their information because it will be good for them. That data ultimately moves from the patient domain to the organizational domain, and they lose control over it, and that drives a lot of resistance to adoption and a lot of fear. And also it allows people to argue that you really don't have my best interest at heart. So we are trying to address that fundamental gap. The second big issue with launching multiple digital health initiatives is how to get them to talk to each other. When I was at Blue Cross, I used to have a vendor day, and I used to have lots of companies come to me and present to me great solutions, one for diabetes care, one for pregnancy care, one for transportation, one for patient-centered medical home, one for wellness and sleep and nutrition management, and so on and so forth. The problem is they're all standalone solutions that don't fit any kind of a long-term care continuity model. So how do I bring all these solutions together, and where is the system of truth, and who actually owns all the multiple identities that are in each network you will end up having? So there are a lot of complexities to achieving this. And our vision and mission is to create a platform that allows the aggregation of various services, healthcare, digital benefit, and payment services that typically is the domain of an insurer or an organization that is trying to do population health management, but to do so using a secure, sovereign data ownership fabric. So we are using blockchain as a way to drive consent and ownership of data that is not in your custody. I can have your data in my custody, but you can still have access control and ownership rights to that data. And the bridge between blockchain and a usable digital health network or a population health management solution is vast. Technology stack at the very fundamental level does not translate into a usable application in the market. So what we have done over the last 4 years is really build that bridge between the promise of a secure sovereign data fabric that you might build by downloading a blockchain from the web and actually delivering a usable application in the hands of the patient or the physician. And there is a lot of steps along the way that you have to fill, such as consent management, security, identity, transactions, payments, business logic, and ultimately a standardized application logic. That is the premise. Now, I'm speaking like a CIO because that's the role I have played in insurance for a long time. but I'm essentially saying to you that when an insurance organization looks to modernize the way it delivers digital benefits and digital health solutions, there is a need for a comprehensive data strategy, application strategy, and integration fabric that allows the simulation of various innovative solutions into a standardized way of delivery to the patient, the last mile relationship. And the way we have done that is we have built an application called the Care Wallet, which is an application of digital apps. And in this Care Wallet, which is a single app in the hands of every patient worldwide, they can join various care networks on the platform, be it a transportation network, be it a disease management network, be it a mental health or a behavioral health network, be it a wellness network, be it a payment network, be it a teleconsultation fabric. Whatever it is that you want to bring, our vision is that no matter how many solutions you need to launch in the market, and you will need to launch multiple solutions to target different population groups, there has to be a unified way to access and use those solutions. And if you don't unify that on the front end, you will never get the adoption or longevity, because you may get a topical use for a few weeks or a few months on a single app, but then when the need ceases to be dominant in their life, the patient will move on to and never use that application again. It's very expensive to re-engage the patient. So let's change the model. Let's give the patient a lifelong wallet, which changes its behavior based on their needs rather than giving them a different app every time. So Care Wallet is a universal lifelong relationship that we want to establish with the patient, regardless of whether they fall in a young and healthy group or in the multi-chronic group or something in between. We can engage them forever, regardless of even whether they are insured with you today and whether they'll exit that policy and come back in 20 years. That relationship can still be maintained over decades. And you do that by creating different need-specific, population group-specific care networks on the platform, which can be either clinical in nature, administrative in nature, financial in nature, or all of the above. But these networks can be accessed from the same application called the Care Wallet, and they deliver different set of services to the patient, regardless of what is the exact set of needs that they have. So you may offer a variety of digital health networks, but I, as a patient, will only join the ones that make sense to me, that I am eligible for, and that I actually need. So when you really visualize this concept, I want you to see a little quick video of how this all comes together. If I have a Care Wallet, I can create various different private circles, which include people I care about or who care about me. And those care circle members can participate in my care journey, regardless of which digital network I'm participating in. I can share with them my appointments, my transportation needs, my prescriptions, my upcoming refills, my missed appointments or checkups, or my upcoming care coordination activity I need to do, get my A1C checked or go see my doc for my annual checkup. All this activity ultimately becomes a personal control regardless of what my needs are. So we are effectively saying to the patient, look, I'm going to give you a variety of tools, and you will choose the tools that are relevant to you and your family at this point in time. And you have absolute control over participation, interoperability, and sharing of your data, and the ability to move data between various networks 100% in your control and with your consent. I'm not going to move your data without your permission, because you will send a card from your wallet to somebody else's wallet with all the network participants in the wallet. And this gives the patient an actual engagement tool that is not specific to the need, but rather a standardized sense of sovereignty and data ownership that they need to join any network. But the beauty is, when you give them that control, we will join multiple networks, which is what we want, to bend the cost curve, to improve the outcome, to reduce the resistance to any kind of a suggestion of better self-care. We need to create that ownership of data between the patient and the network. Now, the other thing that becomes really important is, how do we empower the transfer of value between us and the provider, the physician, or how do we incentivize the patient policyholder with rewards? So Behind the scenes, the platform allows for tokenization of individual healthcare transactions or payments, which means that you can tokenize a single event. What does that mean? You can essentially attach a value to an event that can then transfer value should that event be completed. For instance, if I want the patient to go get their medical exam, annual checkup done, and I'm offering a reward to them, the very act of them making an appointment through the wallet can be linked to an automatic reward step, or them going to the doctor and getting their medical exam done and sharing that record with the with a certain party that has relevance to that would trigger a different payment. So instead of creating very complex payment system, you can do a real-time tokenized payments, which essentially mean a digital voucher that can be linked to any kind of a transaction between any party on the network. Completely streamlines and facilitates things like appointment setting and payment at appointment time, or a member submitted claim, or a incentive for doing the right thing that we want them to do, such as preventative care or a follow up with their prescription. It doesn't really matter. The need of each population group is going to be different. But if we can link a value to an event or a non event, you can deliver that value as soon as that event occurs, which becomes essentially a real time incentive reward model. So when you put it all this together, the notion here is that you, as an insurance organization, should be able to launch population group specific networks quickly. What used to take a year or two or five, we used to cost hundreds of thousands or millions of dollars to stand up a full application stack to build a new network, be it for the diabetics or the pregnancy care or for managed transportation network or for eligibility and enrollment or referral and pre-authorization. Every country has a different model. Every insurance company is trying to deliver better benefits in a more cost-effective way. That vision that you have can be realized in the form of a better network design on a singular platform that makes that process much quicker. So put things in perspective, when I launched several digital health networks 5 years ago, my cost ran into seven figures. $100 million was not an unusual price tag to stand up an health insurance exchange or health information exchange. To launch a diabetic care network cost us $6 to $7 million for about 50,000 patients. The same thing can be done now with much more effective cost and time model, and essentially the cost is 1/10 to do so, and the time frame is 1/10 to launch it, which means that I can launch digital health solutions for a smaller population group than I could do in the past, because it took a certain body of patient population to justify a digital health network. Our vision is to ultimately let you build a digital health network for a population of one. But still, today, you can build a digital health network for a population of 1,000. And that's a huge step forward compared to before, where I had to aggregate the needs of 1 million patients before I could afford to build a digital health network for them. So that granularity lets me as a CIO respond to the CEO and the CEO's requests in how to deliver better care for ever so smaller population groups, which tend to be unique in their need and in their cost model. So with that said, let me give you another example of how this actually works. So we have built a diabetes care network, which allows for patient and a nurse coordinator to do a significant amount of work that typically doesn't get done in terms of preventative care, in terms of curative model that does not require a physician involvement, thereby reducing our cost footprint, but also giving the patient a much better way to manage care leading up to an appointment with the physician. So what can we do before the patient even gets to the doctor in terms of home care, self-care, continuity of care, and compliance of care with care models? So this program was designed in collaboration with Boehringer Ingelheim, a major pharmaceutical company, with the idea that we can help engage the patient in a lifelong diabetes care management rather than episodic care that happens only when they go see the doctor. And the blockchain underlying fabric allows for not just information exchange, but also consent management and full data privacy and control by the patient in what they share, when they share, and who they share it with, leading to better engagement. So this is a live example of one of many networks that have been launched on the Solve.Care platform, but really we are just getting started. Our next step here is to bring this platform into the hands of insurers like yourself to start imagining networks that were previously unthinkable. And that's really the game. The advantage or the objective here is to enable an insurer to segment their population much more granularly, to bring much more granular and pointed digital health networks to that population group, and do so at a fraction of the cost that would previously take us. So finally, I'll give you an example of some very innovative network that one of our joint venture companies is launching. And this is a global teleconsultation network that's open for physicians to join worldwide, subject to credentials, and allows over 4,000 different pairs across countries to be forged between patient and doctor. In other words, and if you were to allow every patient in the world to talk to any doctor in the world, regardless of country, there would be about 38,000 potential cross-border relationships that would be possible logistically worldwide. And this network enables about 4,000 of those out of the box with an intention to reach every patient and every doctor eventually. What is the value of this? It's about access to care. It's about demonstrating that we can deliver both regional and national digital health networks, and the same platform, the same blockchain fabric can facilitate in-country or cross-border payments, appointments, record management, consents, and identity management. And if we can do it at a global scale, we certainly can do it in the context of a single insurance population. So with that said, the core concept that I want you to understand is that to build any kind of a digital health network where data ownership and data custody are separated, you need to manage 5 things: identity, consents, transactions, payments, and data ownership / data custody. And this platform is designed to address all of those 5 things, which makes it very easy for an insurance CIO or a government CIO or a hospital CIO to say, look, I can probably launch a digital health network on this for a very, very narrow population group without having to disturb my entire ecosystem that I have invested in. My existing IT infrastructure does not need to be redone overnight for me to launch a very powerful digital health network, because I can connect them in a manner that I can actually afford and support. So this is the general premise. We have launched 5 networks so far: a diabetes care network around care coordination of diabetics, a global telehealth exchange network around global access to care, especially in countries where there is no immediate and accessible physician population, patient engagement and privacy network, particularly around patient wellness and engagement using team care, transportation management network for subsidized transportation for clinical needs, and provider payment network for real-time physician payments for value-based care model and performance-based payment system. This is just an example. There are many other networks in the works, and we are currently driven by partnerships around the world who are looking to use the platform to drive better care, better outcomes, and lower cost. But all of this is underpinned by the vision that patient privacy, sovereignty, and interoperability of data driven by the patient consent is going to drive better digital health participation than any other model that we can think of. So those are the drivers. We need to ensure patients' access rights, their ability to engage or disengage from a network, and their ability to easily interoperate across networks is the foundation on which insurers, hospitals, government organizations can drive adoption and improve outcomes that we have long sought. I welcome your questions and comments, and we certainly invite you to reach out to us if you have a need or a plan to develop a new digital health solution, be it for all your population or for a segment of your population. We probably can help you think about it in a different way and help you achieve a better outcome at a lower cost than normal technology stacks permit. Thank you for your time. I look forward to the questions, and I turn it back to Yannick.
Hey, thanks, Pradeep. One of the first question I have is the to build such a network with all kind of different actors in the ecosystem, from, and you mentioned a lot of them, yeah, from the medical providers to the insurer. what's your strategy when you start to build this for one specific market, or usually an insurer will like to have his own solution only for him with his own ecosystem? Are you working first with the healthcare provider, or are you working first with government and regulator, or is there a way to work first with one insurer with his partner and then start to basically evolve the network? And would it make sense in terms of cost to start with insurance for
So
you?
I come from the insurance sector. I mean, if you
Okay.
cut me, I would
Yeah.
probably bleed
Yes.
some insurance policy. So clearly, the first and foremost audience is the insurance executive,
Okay.
the insurance CIO, the insurance CTO, the insurance CEO, because ultimately I'm the client for which this platform was built to allow me to serve my membership better. So yes, it's
Yeah.
certainly
Yeah.
the client is, but it is not limited to insurance.
Yeah.
But certainly it has expanded to include hospitals and pharmacies and provider networks and government organizations, because they're all part of the population health management challenge and need. But insurance is our client. So in the context of an insurance company, or whether you're a single region or multi-region or a national or a multinational insurance solution provider, the objective here is for you to let you design digital health networks for a population group. So even if
I
you're
see.
serving a vast population across 20 countries, you're going to have cultural and economic and regulatory differences in
Yeah.
managing
Yeah.
population groups across each territory.
Yeah.
So our vision is to let you build a digital health network that has commonality across all these territories you serve, but then customize it to the need of a population group that might be in Hong Kong versus Singapore. Now, there may
Okay. I
be
see.
language, culture, or even regulatory differences. So each digital health network on the platform can be common to a great degree, but still be configured what we call the care protocol across each region. So this is point one. Point two is that yes, you always have to have a network sponsor. The network is ultimately sponsored by an entity that is looking to drive better outcomes, lower
Yeah. Yeah.
cost, better engagement. So insurance companies are typically the most prolific sponsors of networks, but they are driven by the need to improve their health and wellness of their membership and to retain them and to obtain or expand their membership, but also to do so in a manner that is regulatory and clinically sound, right? We cannot be seen as doing something purely to advance our own cause at the expense of the patient or the physician perception. So digital health networks need to have a certain level of transparency and auditability that allows
Yeah.
the regulator or the physician panel to say, well, yes, this is good for the patient, and yes, it reduces cost, not the other way around, right? So that auditability and transparency is baked into the platform in what we call the care protocol, which becomes immutable and therefore auditable, and therefore it protects us against perceived or real liability.
Yeah,
So
yeah.
insurance
I think it
companies
makes sense. It make me remind some of the initial blockchain initiative in Hong Kong, Singapore, led by the Hong Kong Federation of Insurers. So trying to actually create the network effect, bringing insurer together to build something, to bring a first kind of platform startups that all the industry can use to, and looking into issues like fraud across insurer, for example, at first to solve this exhaustively. That's great. Maybe the last question I have as well. I've actually implemented with Swiss Re and one of our primary insurer in Singapore a few years ago within the regulatory sandbox, the first electronic health records, parametric health, so all the fancy words, using blockchain actually for type 2 gestational diabetes. So the pregnant ladies that develop diabetes is not well covered by the insurer, neither the National Health Security. So we had this idea to leverage a technology like blockchain and to connect to the sensitive data from the electronic health record in the cloud and automate fully end-to-end the underwriting and the claims process for type 2 diabetes, for gestational diabetes. And actually the technology worked really well. This was really not a problem. The problem was more then the customer also adopts quite well. They see if they see the value, and the doctor explain. one of the problem we had was more that at the end of the day, there are still human that needs to input data in the system. And this was here the nurse, for example, in the maternity or hospital that needed to input the data when they are diagnosed gestational diabetes or when they have complication at birth. And it was not done in a real time. Sometimes you have batch, sometimes you have holidays, sometimes they input the wrong information. So at the end of the day, that's something we discussed in the module before. Finding the right balance between technology and human is always what is critical to get the full benefit, yeah, of this solution. And I was wondering if you have one example where you've been able to find this balance right.
So I think in the end, it boils down to incentives and rewards and perceived incentive and rewards.
Yeah, yeah.
I mean, human error aside, errors, unintentional errors, we only can overcome through validation. So that's a whole different topic.
Yes,
And
yeah,
there are
yeah,
ways around that. But the real objective here is to incentivize the network participants in a clear manner. And incentives don't need to be always economic. They can also be through information incentive, they can be outcome incentive, and they
yeah,
can be
yeah,
engagement and power incentive. So when we design digital health networks, we take those into account. How are we making sure that every network participant, as an insurer, if I'm going to have a network to engage the patient's family member, the care coordinator, the physician, the specialty care, the pharmacy, maybe even the transportation driver, I have to make sure that I have appropriate incentive and information which go hand in the hands of each participant that is appropriate. But one thing I will
yeah,
say is that we don't do cloud-based data storage. In our world, every participant has their own set of data in their wallet
yeah,
and
yeah,
choose to share it, which in itself is a strong incentive. If you know that data sharing drives better outcome for you or an incentive or a reward for you, you're much more likely to make sure the data is collected and shared than if
yes,
you feel like some big brother is holding all the information and you are basically disintermediated from it. So it's a
yeah,
bit
no, fully agree.
philosophical difference. The way
Yeah,
we are approaching it is also fundamentally a different philosophy of patient engagement and empowerment. Not, we want to change the terminology from being a policyholder or a beneficiary of to an effective, engaged, sovereign human being who we
yeah,
respectfully want to collaborate with.
fantastic. Well, the time's off, so thanks a lot for your presentation and taking the time to reply the question. And we will now move to the next speaker. Thanks, Pradeep.
My pleasure. Thanks for having me.